Hi, my name is Anthony Silver. I'm the founder and clinical director of Grey Matters in Westport, Connecticut. Today's presentation is on the real-time swLoreta neurofeedback of veterans with PTSD. Before we start, I thought it was worth just reflecting on the evolution of the diagnosis. In the First World War, PTSD was referred to as shell shock. And it was named that by the soldiers themselves, who were just trying to come to grips and understand how they were experiencing the trauma of war. In the Second World War, it was more officially referred to as combat fatigue, with troops refusing to go back to war and struggling. And in Vietnam, it became officially known as post-traumatic stress disorder. So PTSD, according to the DSM, is caused by exposure to emotionally or physically harmful or life-threatening experience. Increasingly now we're actually hearing about the diagnosis of complex PTSD, which is more related to chronic childhood experiences of emotional trauma. But today we're really discussing PTSD in soldiers. PTSD affects 3.5% of US adults each year. There is a lifetime prevalence of PTSD in adolescents, age 13 to 18, of 8%. 1 in 11 people will be diagnosed with PTSD in their lifetime. And women, critically, are twice as likely as men to be diagnosed with PTSD. According to the DSM, there are 4 categories of symptoms: intrusive memories, thoughts or dreams; avoidance, avoiding reminders of places or people that trigger the traumatic events; changes in cognition and mood, distorted beliefs about the self and or others; guilt, shame, a lack of positive emotion such as satisfaction or joy; and changes in arousal and reactivity. So you see irritability, emotional reactivity, recklessness, self-destructive behavior, an increased startled response, either increased or decreased sleep, chronic anxiety, and difficulties with concentration. So I thought it was interesting in looking at PTSD in veterans to see if there's a similarity or an EEG biomarker that we can see in QEEG profiles of PTSD. I also want to show how differences in PTSD profiles relate to symptoms. And what I thought was especially interesting was seeing if there are particular factors that predispose PTSD severity. Are there personality characteristics? Are there differences in training or background that change the severity of the PTSD experienced by soldiers? And finally, how do we treat PTSD using swLoreta neurofeedback? So here I'd like to introduce you to 4 quite different US soldiers, all of whom were treated at Grey Matters within the last few years. Ross, the first one who you'll hear from later, was a US Marine. He was a radio operator serving in Iraq. His convoy was ambushed outside Baghdad, and his truck was blown up when he and his platoon were standing next to it. So he actually wasn't physically injured, but he witnessed his colleagues, his fellow soldiers, being pretty severely injured and some killed around him. So in terms of symptoms, he has survivor's guilt, very restless sleep, vivid dreams, nightmares, avoidance, and what he describes as an inability to feel happiness. He points to his heart and says, there's a hole here. And like many soldiers, he has digestive issues. Scott was a Chinook pilot. He served 2 tours in Afghanistan, flying special forces into combat. He was repeatedly shot at while he was flying. He described a change in schedule where the rotation shifted and a flight that he was supposed to be piloting was changed, and a friend of his piloted his helicopter instead. This change in the schedule led to his friend being shot at, dying, along with the crew, when it would have been Scott who was flying previously, but had been replaced. So Scott also has a huge sense of guilt, anxiety, racing thoughts, depression, survivor guilt, and he's especially triggered by overstimulating environments. Bob was a Black Hawk pilot, serving 2 tours as a pilot. He later went on to direct all air operations over Iraq, working 16-hour shifts, 7 days a week, working astonishing hours. He returned to the US and became a firefighter, but is now currently on medical leave because of his struggles with his emotional regulation. Again, he suffers from guilt, emotional reactivity, and digestive issues. Interestingly, the digestive issues these men actually believe is caused by something environmental while they were serving. Mike was the highest functioning of the soldiers that we work with. He was not just a Navy SEAL, but he ended up being head of the Navy SEALs. He served in Iraq and Afghanistan, awarded multiple medals, ended up serving in the White House under President Bush and Obama. And despite an astonishing history in combat, despite apparently attending the funerals of 60 of his friends and amputating one of his friend's legs in a combat zone to help him evacuate, Mike reports no symptoms at all. And as you'll see, his QEEG actually supports that. So we treated the other 3 soldiers. So this is Ross pre-treatment, showing overarousal, Brodmann area 23, the posterior cingulate, measuring 2.16 standard deviations from the norm at 26 Hertz. Scott, the pilot, the Chinook pilot, again, Brodmann area 23, the posterior cingulate, 3.2 standard deviations from the norm at 24 Hertz. And Bob, the flight director, less severe symptoms. 1.5 standard deviations was his most deviant finding. Again, Brodmann area 23. Mike, when we did the QEEG, we struggled to find any area that was significantly deviant from normal. The most difference we found was in the thalamus at less than 1 standard deviation at 22 Hertz. So with Ross, Scott and Bob, we trained the salience network. So the salience network is responsible for the awareness and processing of both internally and externally generated sensory information. Dysregulation of the salience network is associated with various psychiatric disorders, including anxiety and post-traumatic stress disorder. And interestingly, overarousal in this area is often confused with ADHD, but really it's a disorder of dysregulation and anxiety, and not the kind of profile that would respond to a stimulant medication. So what you're looking at here is Ross, April 2nd, 2022, beginning of his treatment, and in December, after, I believe, close to 100 sessions of neurofeedback, going from 2.16 standard deviations from the norm to 1.76, and in a vastly reduced area of the brain. So the area of overarousal has significantly shrunk. And critically for Ross, his symptoms dramatically improved, and he started dating again and enjoying life and did very, very well. This is Scott, pre-neurofeedback and post, going from 3.21 standard deviations from the norm to 1.7. Again, Scott was able to return to work and function properly. And finally, Bob, the flight director, going from 1.5 standard deviations from the norm to 1.13. So all three soldiers, significant improvements in measurable brain function and in real life function, which is the most important. So what I'd like to do here now is just let you hear from Ross himself, describing the difference in his life after neurofeedback.
I feel now like I have a new take on life. Like I'm ready to take on the remainder of my life as if it's a new day. 2005, I was pulled out of college to a deployment to Iraq. Over time, got worse and worse and worse. My experience at Great Matters has been, nothing but rewarding. For the past 16 years, I've been struggling to find hope. It just blows my mind how I'm able to move now versus when I first started.
And that's Ross being greeted by the dog. Thank you very much.